Yeah, at the current time, if you're dealing with a locally advanced patient, molecular testing does not play a clear role. It really does not impact on choice of therapy. For metastatic disease, on the other hand, molecular testing does have an impact. Although we are in the era of sort of whole exome sequencing and next generation sequencing of cancers, it still does play a limited role in identifying treatments for gastric cancer. The main one that is standard is HER2 testing. In metastatic disease, if a patient's HER2 positive, we include trastuzumab as part of chemotherapy. And now we have to consider in metastatic disease either MSI or DNA mismatch repair protein testing or PD-L1 testing. We now have evidence that anti-PD-1 drugs, particularly pembrolizumab, has a signal of activity in PD-L1 positive gastric cancers and refractory disease, and has even a more significant activity in MSI high or DNA mismatch repair deficient gastric cancers. So in the patients up front, we do HER2 testing that impacts on initial treatment of metastatic disease. When they become refractory to chemotherapy, we now have regulatory approval of pembrolizumab for either PD-L1 positive or MSI high gastric cancer. In terms of everything else that we see in genomic sequencing, it's interesting and it's a research question, and maybe we can identify in 1% of patients some mutation that they might be an appropriate candidate for a trial. But typically we find p53 mutations, we find amplification of receptor-associated tyrosine kinases, of which the only relevant one is HER2. So although genomic testing is becoming part of a standard practice, in reality there are really three things that we need to test for: HER2, MSI, and PD-L1. Where we suspect gastric cancer in a young patient, so typically any patient under the age of 50, or when we see a significant history of gastric cancer in the family, we should think about CDH1 or familial diffuse, hereditary diffuse gastric cancer. That's not a subtle presentation in a family. Typically these are patients that develop gastric cancer in their 30s and 40s. We see it generation after generation. So just because someone's under the age of 50 doesn't mean they have CDH1 mutation gastric cancer. There's also an association with lobular breast cancer. So that's not routinely tested for. We do have consideration for doing genetic testing and counseling in any patient that develops gastric cancer under the age of 40 to 50. But usually we're not going to find a heritable mutation unless there's another family history. And CDH1 gastric cancer is relatively rare. Other rare familial gastric cancer syndromes include Lynch syndrome, where we see the association with colorectal cancer and GYN cancers in women. BRCA, breast cancer, has an associated increased risk in gastric cancer. And then we talked about non-polyposis Lynch syndrome, also the polyposis syndromes, Peutz-Jeghers, juvenile polyposis, FAP, all have associated increased risks in developing gastric cancer. These are all rare. So typically we would consider genetic testing in a young patient, or if there's a strong family history, but even in a young patient we're not likely to find a mutation. There isn't a situation occasionally where that patient is the index member of the family. So young patients we do test. Older patients we would test only in the context of a strong family history.